So welcome everyone to our webinar today, Keys for Effective Treatment of Anxiety, Interoceptive Exposure, and Safety Behaviors. I'm Jill Levitt, and I'm the Director of Training at the Feeling Good Institute, and I'm happy that you've all made it here. What is Feeling Good Institute? So we are on a mission to improve lives with effective therapy. That's our goal, and we accomplish that in a couple of different ways. We train and certify therapists in evidence-based CBT. We also have a group of therapists that are affiliated with Feeling Good Institute that are kind of highly skilled and vetted therapists that provide therapy through the Feeling Good Institute, and we do lots of weekly training with those therapists and are continually improving and using the deliberate practice model for practice and improvement and kind of constant improvement. We have lots of services to meet clients' needs. We have video-based therapy across the US and Canada, and we have treatment centers in New York and Silicon Valley, Canada, and Israel. And we offer traditional outpatient therapy as well as intensive therapy, where people will come in from out of town to work with therapists for several days, for several hours a day over the course of several days to do sort of a more efficient dose of therapy. And we have lower fee options as well. So now I'll get into kind of the heart of what we're going to be talking about for the next hour. This is sort of my rough plan to spend about a half an hour with you guys teaching you about interoceptive exposure, to give you guys a chance to actually practice an interoceptive exposure exercise with me to see what that's like. And then to talk some more about dealing with safety behaviors. And I'm going to leave 10 minutes at the end for Q&A. And Mike Christensen's going to help me facilitate the Q&A. So if you have any questions throughout the presentation, you send them to Mike in the chat box, Mike Christensen, and Mike will hold your questions for the Q&A and kind of facilitate them. I won't be able to answer all of them, but hopefully I'll get to some of the ones that are maybe most commonly asked from the group. And then I just always like to remind people that if you're wanting to get your continuing education credit at the end, you do need to check in for attendance on the course page. That was kind of required before you got the Zoom link anyway. You need to be present for the whole hour, and you need to complete the CE survey right after the workshop. That's also on that workshop page. So right after the Zoom link, if you clicked continue, you get the CE survey. And once you complete the CE survey, you're actually automatically given a certificate of completion. If you have questions, I ask you not to email me, but to actually email certification@feelinggoodinstitute.com, questions about getting your CE survey. And I'll remind you guys about that at the end. So I'm gonna run a quick poll for you guys really before I get started. So I'm gonna launch the poll right now. Hopefully you guys can see that on your screen. Asking you, do you feel confident using interoceptive exposure in your therapy practice? Like, you guys could be teaching this instead of me. You know, yes, no, or just a little bit. You know, I know a little bit about interoceptive exposure. It's helpful for me to kind of gauge where you guys are at in the presentation today. So I'm just going to give you another 5 seconds and then I'll end the poll. So just click kind of no, yes, or a little bit. Okay, I'm gonna end the poll. It just gives me a little bit of a sense, and I'll share the results with you guys. It looks like about 40% of you said, no, I don't know how to use it at all. About 13% of you said, I know all about it, but I'm still excited to learn more today. I put some words in your mouth there, and about 50% of you said, I know a little bit, but I don't know enough to use it confidently. So it sounds like lots of people either not knowing anything or just knowing a little bit. So that's helpful. So I think that interoceptive exposure is an extremely effective and helpful treatment strategy for most patients who struggle with anxiety disorders, and not only panic disorder, which is the population that it was originally developed for. And that is because most anxiety disorders, and not all, but most patients who have an anxiety disorder also have some level of fear of their bodily sensations, some discomfort with the experience of anxiety. And this is clearly problematic because in response to fear or anxiety, you experience changes in the same bodily sensations that you fear. And so if you kind of follow along, in many anxiety disorders, we have some fear or some anxiety that leads to bodily sensations, right? Heart racing or trembling or sweating, some level of anxiety you feel in your body. And then if we misinterpret those sensations as dangerous, if we don't want those sensations and we feel afraid of those sensations, we then feel more afraid. And so we have anxiety followed by physiological sensations, followed by misinterpretation of those sensations, followed by an escalation in anxiety. And so there's a sort of positive feedback loop. And so if that's the case, then addressing one's fear of the sensations will be critical to treating any anxiety disorder, right? So if most patients who experience anxiety have some anxiety or discomfort about their sensations, helping them to overcome that fear or discomfort will actually also help them to overcome their anxiety in general. Now, by definition, patients who have panic disorder are afraid of the physical sensations of anxiety. That is part of the definition, right? They have panic attacks and then they're anxious about having more panic attacks. So they're afraid of the sensations. But this is not only the case in panic disorder. So if you think to yourself when you're treating a patient who has OCD, of course, they're afraid of the consequences. Like, for example, if I don't wash my hands, I'll contract an illness and die, or I'll contaminate someone else. But also, if you talk to patients with OCD a lot, quite often they're also afraid of the anxiety that comes up. So when you say, why do you need to wash your hands? It's not only to prevent this terrible thing from happening, it's because I can't tolerate what it feels like. I can't tolerate the anxiety. And so patients with OCD can also benefit from interoceptive exposure, focused on helping them to learn how to tolerate those feelings of anxiety. We see that in the case of PTSD, in the case of social anxiety, where people are not only worried about embarrassing themselves, but they're also worried about having a panic attack in a social situation. And then interoceptive exposure is a treatment strategy that can help them as well. Many patients I see that have a fear of flying are not only afraid that the plane will crash, but they're afraid that they're going to be on an airplane and feel incredibly anxious and panicky. And that escalation, right, is what we can help them with. Test taking anxiety. And so the list goes on. If you think in your mind about the various patients you have in your practice right now or that you've seen over time, you kind of ask yourself, well, how many of them had at least some level of fear, anxiety, discomfort with the sensations in their body? These are the kinds of patients that will benefit from interoceptive exposure. And it's important to know, I'm not saying treat every patient with interoceptive exposure or that that's the only thing you need to do, right? It's just one treatment strategy in your hopefully big toolbox, right, of tools that you have to help your patients. So what is interoceptive exposure, right? It essentially means, the definition is exposure to bodily sensations, right? So situational exposure is when we're going to go out there and face the situations that make us anxious or make our patients anxious. Interoceptive exposure means we're going to expose our patients to the bodily sensations that they're most afraid of. So the goal of interoceptive exposure is to help your patients to elicit these scary bodily sensations, things like racing heart and sweating and trembling and shaking and dizziness. So to elicit these fearful, uncomfortable bodily sensations, to activate any kind of unhelpful beliefs associated with them, like I'm going to pass out or lose control or not be able to tolerate it. And to bring these sensations on without any kind of distraction or avoidance. So we're not saying bring on the sensations and do diaphragmatic breathing or bring on the sensations and try to think of something happy. The goal is just like with any exposure, it's to fully bring on these sensations without any kind of distraction or avoidance. And if we can do that, the new learning occurs, right? The new learning that we want to occur is that these sensations might feel uncomfortable, but they're not dangerous. That nothing that I'm afraid would happen, like losing control, dying, going crazy, passing out, that none of those things actually happen. I might feel dizzy, but I don't actually pass out. And so these are sort of what we want to accomplish when we do interoceptive exposure. So the goal then is to help your patient to break the link between the experience of physical sensations and the fear response, so they can have those sensations and not be afraid, right? And so if you think about it, I can spin and feel dizzy, but I don't feel afraid of feeling dizzy, right? So it's totally normal to have a whole range of physical sensations throughout our body or throughout our lives, and especially when we're anxious, but we don't need to be afraid of the sensations themselves. And once that happens, once your patient gets to a place where they can break that link between sensations and fear, then they no longer fear feeling anxious, which is part of the battle. It's most of the battle in panic disorder, and then it's part of the battle in a lot of these other anxiety disorders. And this way, when your patient feels physical sensations in their body related to anxiety or anything else, like related to drinking too much coffee or, eating too many burritos or something, when they feel those sensations in their body, they won't be afraid of them. And so then those sensations won't escalate, right? We'll have sensations minus the fear, which means the sensations are there as long as they're there and then they go away, but they don't escalate and they don't turn into panic. So I put this slide together. I thought it was kind of fun to just remind yourself, because it's hard for therapists even. We get a little caught up in our patient's anxiety to remember that uncomfortable does not mean dangerous, and we don't need to avoid things that are uncomfortable. And these are examples of things that you might do, daily or on vacation or things like that, that bring on what could be uncomfortable sensations, but that people choose to do all the time, right? Lots of forms of exercise, including weightlifting, causes lots of pain and soreness the next day. A really good run, you might even feel breathless and winded and super sore the next day. And yet, you choose to do this with your free time, and people pay lots of money to go skydiving or ride roller coasters. And these are all activities that bring on pretty intense physical sensations, and yet they're not dangerous, right? We're not afraid of them. And so we need to have it really clear in our minds that uncomfortable, or sensations does not equal danger. And therefore our patients don't need to avoid feeling sensations. We don't need to be afraid of making our patients feel sensations. It's kind of the opposite. We're going to start to learn how to sort of lean in and help our patients to go bring it on, show me what you got, and feel those sensations. So how does interoceptive exposure lead to change? Much in the way that all forms of exposure lead to change. And we don't know exactly. There is research on these kind of various ideas. But one way that interoceptive exposure and other forms of exposure can lead to change is through what's called habituation. And why it's important, by the way, for you to know this, if it feels kind of jargony, is that if you're doing interoceptive exposure with your patients, you're going to give them a rationale for it, right? You're going to tell them what it is, and you're going to tell them why it works or how it works. And so one way that it could work is through what's called habituation. This is kind of the idea that if we engage with a stimulus repeatedly, right, kind of over and over and over again, it no longer has the power to evoke anxiety for us. So if we are afraid of heights and we hang out in high places kind of over and over and over again, we'll get used to high places and no longer really be afraid of them. And the same thing with physical sensations, right? Through repeated exposure, your response, your anxiety will come down. So that's kind of one way that it may work. Another idea, obviously, is that if we actually engage in these exercises, right? If we bring on a racing heart through jumping jacks or high knees or different kinds of activities, and the patient realizes that even when my heart is racing pretty fast, I don't have a heart attack, I don't lose control, I don't, go crazy or pass out, new learning occurs, right? So basically we do the exposure long enough that the patient can realize, oh, I had really strong sensations, but none of these catastrophic things happened. And there is again, I won't go into the researcher, but there is kind of a theory that's called inhibitory learning, and that has a lot to do with setting up exposure to help your patient kind of violate their expectancies, meaning to learn that the thing they were most afraid of happening didn't actually happen. And so to this end, you can think of exposure, any kind of exposure, as a set of behavioral experiments. I'm testing the hypothesis that I'll pass out or lose control or go crazy. And we know, of course, that none of these exercises are going to lead to any of these negative consequences, right? And so that's sort of how it works, is that patients get used to the sensations and that they learn that nothing catastrophic happens. So for those of you who really don't know what interoceptive exposure is, these are just a list of some of the kinds of examples of exercises that we can do with our patients. So again, if the goal is to bring on the sensations that commonly occur when one is anxious or panicky, we're going to think of what are exercises that we can do to bring on those sensations. So we can do jumping jacks or high knees or some kind of physical exercise to raise your heart rate. Patients can practice holding their breath, and I'll show you ways of doing this. We're not just like, oh, go practice holding your breath, right? There's a methodical way to do this, but patients can practice holding their breath if they're a patient who has a fear of running out of air or not being able to breathe. A lot of patients are worried when they get really anxious that they'll be breathless, or that their airway will be constricted, something along those lines. And for those patients, you can have them practice breathing through a really skinny straw, like a coffee stir, not like a big McDonald's straw, but a thin straw. We can have patients who are worried about being dizzy. We can have them spin in a chair, right? Or stand up in the middle of our office and spin in place and then sit down. And that will surely make them feel dizzy. And again, uncomfortable. I'm not like thrilled about feeling dizzy, but not dangerous. I do these exercises with my patients. There's zero harm in doing any of these exercises, right? And then finally, hyperventilation, which is the one that I like to use actually the most, because it brings on, for me and most of my patients, the most sensation. So if you hyperventilate or kind of forcefully exhale for a little bit, you'll feel lightheaded and you'll feel dizzy, and sometimes you'll even feel a little bit of tunnel vision. And again, I'm not asking people to do this for half an hour, but if we do this for 30 seconds up to a minute, we'll bring on a lot of intense sensations, but not put ourselves, in danger in any way. So you can find, if you Google online, interoceptive exposure, you can find lists of all sorts of different activities you can do with your patients. And you can also be creative here. Like if you think of an exercise a patient could do that is, medically safe, that might bring on a sensation, that they're uncomfortable about, kind of the sky is the limit. Now, that being said, when we do interoceptive exposure, there are kind of two phases. The first phase is what we call symptom induction. That's basically where we're going to do a range of different exercises with our patients to see which ones bring on the sensations that are most uncomfortable. So we're not trying to do exercises that are fun. We're trying to do exercises that bring on sensations that the patient doesn't like, that are most similar to, let's say, naturally occurring anxiety for them. And this is kind of interesting because some patients, this is why people are so, individualistic, is some patients will be quite sensitive to a racing heart. That's what they tune into. Other patients might be really scared of feeling dizzy. And so when you do the symptom induction, you pick a couple different exercises. I have kind of a list of exercises that I have my patients choose from, or that I choose with them. And we'll pick exercises that we think will be uncomfortable, that they will not like, and that they basically need to learn how to get comfortable with, right? And that's how we pick those exercises. And then after we actually kind of cycle through a couple exercises. So for example, let's say I had a patient who was sensitive to a racing heart, and maybe even they stopped going to the gym and, tried not to let their heart rate get above a certain level. And so they're really avoiding experiencing this racing heart. So I might have them do jumping jacks. And in the symptom induction phase, you just have patients try a couple of different exercises for as long as they are willing to bring on sort of some sensations, and then you record some data. And I'll show you on the next page what you record. But remember, this is where we're curious. And so we'll start to collect some information. Okay, so jumping jacks actually cause the patient some anxiety, breathing through a straw wasn't very distressing to them, hyperventilation was. And so we go, okay, we know there's going to be like 2 exercises at least that are going to be really useful for us to target during exposure. So think of symptom induction as data collection. I'm not trying to get my patient over their fear. I'm just trying to understand which exercises are going to be useful. And then in the exposure phase, we're going to, just like any other form of exposure, we're going to say, okay, here's the exercise we're going to do. We're not going to avoid or distract or stop early. We're going to do this exercise, and then we're going to record some things, which I'll show you. And then we're going to repeat it and repeat it and repeat it. So that's what the exposure phase is going to look like. So let me share with you a little bit more about each of the phases. They're fairly similar in terms of the data that you're going to collect. And this may look complicated, but think in your mind, what I want to know essentially is like what the exercise was, how long they did it, right? So this is pretty intuitive. What sensations came up for them? So did they have a racing heart? Did they have difficulty breathing? Did they feel dizzy? Did they feel hot? So what sensations do they feel? And then how strong they felt them, 0 to 10, right? So I would record, for example, jumping jacks, 30 seconds, and then heart racing, sweaty, dizzy, and then how strongly I felt them, 8, 7, 6, that kind of thing. And then finally, the last column is anxiety rating. And this is important for people to think about, which is, remember that sensations is totally different than anxiety. Because I, Jill, could do the same exercise as my patient. I could feel the same sensations of them at an 8 or 9 or even a 10, but presumably because I don't struggle with this, my anxiety rating might be a 0 or a 2. So you want to ask your patient about the sensations they feel, how strong they feel those sensations, and then how anxious they feel. Right? And recognizing that those are 2 very different things. And our goal in the end, no matter how many times they do an exercise, they're always going to feel sensations, right? I'm not going to do jumping jacks and not feel some heart rate elevation, but I may be able to feel the same sensations and then drop my anxiety. That's the goal with repeated exposure. So symptom induction is the goal, is just to determine which exercises actually are the most distressing, like moderately distressing or more. And those are the ones that we want to repeat. The ones that don't bother the patient, they can do it and it doesn't matter to them, doesn't cause them any anxiety right off the bat, are not ones we need to repeat, right? We're not trying to get them fit. We're just trying to figure out what actually drives anxiety, right? And those are the ones that we're going to want to repeat. And then in the exposure kind of phase, we're going to actually take that exercise, like take one exercise, let's say it was hyperventilation, and then we're going to actually have them practice it for a designated length of time, let's say 30 seconds, 45 seconds, however long it took them to get kind of a good dose of symptoms. And we're going to have them practice it. So we're going to just have them actually do the exercise, and then we'll have them stop. And we'll write down these ratings, how long they did it, how strong the sensations were, which sensations, and how anxious they felt. And then we're just gonna kind of give them, a couple of minutes to sort of get their breathing back to normal if they were, if they had kind of an elevated heart rate. When you do an exercise with your patients like this, most of these things will come down pretty quickly, right? So if we're running in place really fast and we have an elevated heart rate, a minute or 2 later, these things will be, close to normal, and then we'll repeat it. And so the whole point of doing the exposure versus the symptom induction is that we're going to actually repeat the exercise. Now, I've been doing this for a long time, and my sort of like magic number, but it's not always the same, is basically 3 times in a row. It's my goal, and there isn't a way you must do this or like an exact manual that has been researched to be just the right way. But my goal is to have my patient repeat it a number of times, and that is to quickly get over any kind of avoidance to doing the exercise. So they do it, it's uncomfortable, it feels a little scary. We kind of take a break, we kind of talk a little bit about what the exercise was like, and then we practice it again, and then the same thing, and then we practice it again. Quite often, I mean, you might be really surprised to hear this, but I find that even by the 3rd time a patient does it in session with me, they're considerably less anxious than the first time that they did it. But if they are or if they aren't, it doesn't really matter that much. The point is that they need to repeat it for homework. So if they do it 3 times in a row and they're still feeling quite a bit of anxiety, but again, nothing catastrophic happened. So they already know that, you know, their sort of anxious thoughts have been disproven. But my goal is then to have them do it for homework. So I have them do the same thing that they did with me in session 3 times in a row every single day this week. From a time perspective, it's going to take for sure no more than 10 minutes, right? It's like maybe going to take 6 to 8 minutes for them to do their interoceptive exposure practice. So everyone has time to do this. And the most important thing is that they do it every single day for homework, because doing this once a week is not going to cut it. This is what I feel about all exposure, is that the more frequently one does it, the more regularly do it, the more quickly they'll get over it. Most of my patients do it every day for a week, and the next time I see them, that exercise is no longer anxiety producing for them. Some people it takes a little longer. And then we move on to another exercise. So what I want to do with you guys is invite you actually to do a symptom induction exercise with me. Now, I will say this actually, and I'll rewind and say one quick thing that always comes up in the Q&A is, what if my patient has a medical problem? So that is a wonderful question you're asking me. Now, if I'm ever seeing a patient who has, let's say, panic disorder, almost all the time they will have already been checked out medically, right? Because most patients who have panic disorder are convinced by definition that something is terribly wrong with them and that they have a medical condition. So most patients who come in to see you with panic disorder have already been cleared by a cardiologist. And that's why they're coming to see you, because if they actually had a cardiac problem, they wouldn't be coming to see you for the most part, right? So most patients that I see who have significant anxiety symptoms will tell me, oh, and I went to the ER and I had an EKG and they said there was nothing wrong with me. So, you know, for me, if a patient explains that to me, that's perfectly sufficient. If you have any concerns about doing an exercise with the patient and thinking that it's medically contraindicated, then basically ask them if you can have a release of information to communicate with their doctor. But remember, the things I'm asking patients to do, like running in place or jumping jacks or breathing through a straw, these are not things that cause harm to, you know, anyone. And most cardiologists who have patients who have any kind of heart issues actually want them to exercise regularly. So I'm not giving you my blessing to say every patient can do all of these exercises, but if you're concerned, the answer is, you know, ask your patient if they've been worked up medically, and if you actually have concerns because the patient has cardiac or other kinds of health issues, seizures, things like that, 100%, just ask for a release of information, clear it with a doctor. And I wouldn't do anything that I felt afraid would actually cause harm to my patient. So the reason that I said that here was to say, if any of you, I'm inviting you to do an exercise with me. If any of you are concerned about the impact that it will have on your health, please feel free to not do this, right? You are doing this, you know, because you're choosing to do this. And if you don't want to do it with us, that's perfectly fine. So what I'm going to do with you guys is we're going to sort of imagine that we're in a therapy session. You're the patient in this session. And I just kind of want you to see what it feels like to do one of these exercises. So the one that we're going to do, and I'm choosing this one because it's the one that brings on the most sensations for most people reliably, is hyperventilation. So I'm going to show you how to hyperventilate and what I do with my patients. Again, I do all the exercises with my patients the first time. You don't have to, but the reason that I do that is just with the spirit of, like, you know, there's nothing dangerous here, and it's very helpful for patients to see me do the same thing with them. So what we're going to do is, when I tell you it's time, I'm actually going to have you guys, if you want to, practice hyperventilation with me. And then what you're going to do is, just like you would if you were my patient, I'm going to have you do it as long as you can do it until you feel some significant sensations. And so that could be 10 seconds for some people, that could be 30 seconds, 45. I'm going to stop everyone at a minute, you know, so we can keep going with the webinar, but feel free to do it until you feel some sensations. And then as soon as you do, please write down. I'm going to leave the slide up. So you're going to write down exactly what it says here. You can already write down hyperventilation, but then make yourself a little chart like this, right? With columns like this. So you're going to write down the length of time that you do it, because we're all going to do it for a different length of time whenever those sensations feel noticeable. And then I want you to quickly write down what sensations you feel, because you will feel a range of sensations. Write down what sensations you feel, how strongly you feel each of them, right? So please know, if you're not going to do this exercise with me, you're probably not going to do this exercise with your patients, right? So give it a try if you're willing to. Write down what sensations come up for you. It'll be very interesting for you to feel that. How strong, from 0 to 100, each sensation. So racing heart, difficulty breathing, etc., dizziness. And then how anxious you feel, 0 to 10. So whatever scale you want to use, 0 to 100 for each one, or 0 to 10 for each one. And remember that you may feel anxious and you may feel a lot of sensations and not feel anxious at all. And it kind of gives you a little cue into how sensitive you are to physical sensations too. So I will start the exercise with you guys, but then I will stop and I'll just tell you guys. So I want you to continue until you feel sensations and write these things down. I also want to tell you guys, it's interesting with hyperventilation. So some people feel sensations right away and other people it takes longer, and it doesn't have anything to do with fitness either. I don't quite understand what it has to do with, but so if you start to feel lightheaded and dizzy within 10 seconds or something, that's fine. And if it takes you a little longer, that's okay too. So this is what hyperventilation looks like when you do it with your patients. I find this is most effective, is basically a very forceful inhale and a forceful exhale. So kind of like this. Okay, so I'm going to invite you guys to try it with me now. And I'm going to set my timer for a minute, or I'm going to, do a stopwatch for a minute here. And then I'm going to stop and I'm going to ask you guys to write your data down. Then I'm going to ask you to send your data. You don't all have to do it, but a couple of people send your data to Mike in the chat box, so Mike can share some of this with me. Okay, so we're going to start now, and you're going to go like this. And I'm not going to continue on, but I'm going to let you guys do it. It's been 20 seconds. I'll give you guys 30 more seconds because I do see some people are still doing it. If you're not feeling many sensations, you can try doing it more rapidly, like some people, the slower, deeper works, and some people more rapid works. I'll give you 10 more seconds and then I'm going to stop. Okay, so that was a minute. So then take a minute, if you didn't already, and record how long you did it for. What sensations came up for you? So those are one word, heart, well, that's 2 words, but heart racing, just description, sensations. How strong, 0 to 10 or 0 to 100? Were each sensation, you're rating each one separately. And then how anxious, that's just a global anxiety rating, 0 to 10 or 0 to 100. And then maybe send, if people can real quick, just send a note to Mike, just write down like your sensations, heart racing 8, trembling 4, lightheadedness 3, just sort of send them to Mike in the chat. And I'll just have Mike read these just so we can sort of all learn a little bit about what kinds of things come up for people. What do we have, Mike?
Yeah, they're coming fast and furious here. 20 seconds, dizzy, 50, lightheaded, 60, heart racing, 20, dizzy, duration 1 minute, dizzy 4, heart racing 3, anxiety 6, warmth 6, anxiety 2, 15 seconds, intensity of sensations 4.5, anxiety 3.5, 50 seconds, dizzy 70, lightheaded 70, nausea 40, anxiety down to 0. Length of time 30, hot 5, dizzy 6, anxiety 3. 45 seconds, dizzy 7, lightheaded 6.
Okay.
Yeah.
So thank you. So yeah, there's a range of symptoms that people experience, right? Dizziness and lightheadedness is the most common. I don't think I heard anyone say it, but a lot of people say dry mouth. Some people feel some tunnel vision. Some people feel some tingling in their fingers. These are all really common sensations. And if you think about it, when people are anxious, they hyperventilate. I mean, they don't necessarily hyperventilate as forcefully as we just did, but that's what happens. A lot of hyperventilation and shallow breathing. And that's actually what's responsible for many of the sensations that people experience when they're having a panic attack. Now, again, you all, experience sensations, right? But know that this is not dangerous. It is not harmful to do an exercise like this, for 30 seconds or a minute. So let's see if I want to say anything else. So I'm going to move on to talking a little bit more about applications of interoceptive exposure, and then we're going to start to talk about safety behaviors, and then we'll have plenty of time for some questions and stuff too. One question I sometimes get is and maybe I'll give you, I have a little bit of time, so I'll give you one sort of anecdote. So one question that therapists will ask me is, what happens if my patient freaks out? And I mean, that's a good question to ask for any kind of exposure or any kind of therapy that you're doing where you're encouraging your patient to confront their anxiety. So I will share, my answer is I very calmly, basically commend my patient for doing something that's challenging and hard, and kind of remind them that uncomfortable is not dangerous, and it feels really uncomfortable to do these exercises, but that actually I feel really kind of excited that this is causing you so much discomfort, because I feel like we're on to sort of the very thing that's going to help you to overcome your anxiety in the long run. And so it brings me to one anecdote I'll share with you guys, and then we'll move on to safety behaviors. But I had a patient that I treated, and people who have heard me talk about this have heard this story before. It is my favorite story to share about this because it was so extreme. But I was treating a man in his 50s for, he came in actually to see me for claustrophobia. So he basically said, for my whole life, I've been really sensitive to sort of small spaces, and I don't really love feeling enclosed, but it's become much more of a problem for me recently. I've noticed that even when I'm at work in meetings in small rooms, I want to leave. I want to get out quickly. I am really sensitive to feeling hot and confined. And so I've started wearing kind of shorts and t-shirts to the office because I just want to feel sort of like cool and unconstricted. And my wife and I, we carpool with this other couple into the city for the symphony, monthly. And I've noticed I don't even like being a passenger in the car. And so he said it was kind of a lifelong thing, this claustrophobia. And he actually had sought therapy multiple times in the past for it, and then nothing ever helped. And so we kind of let it go, but now it's really interfering in his social life, interfering at work, et cetera. And so, I did a thorough evaluation, and we did some cognitive therapy stuff to begin with. And then basically, in assessing him, found that he was super sensitive to physical sensations, that it wasn't just that he was afraid of sort of being stuck, but he was afraid of, not being able to get out because the sensations were so strong. And so I explained to him the rationale for interoceptive exposure, and with lots of excitement that I feel like this is going to be a really crucial part of you getting better, actually, because I can see that what happens is that you feel uncomfortable, and then you're so uncomfortable feeling uncomfortable that you think you need to escape. And he agreed. And so the sensation that he was the most distressed about was really, and this is common with claustrophobia, was that he would run out of air. And so I thought, well, let's try the breathing through a coffee stirrer. That might work for him to mimic that sensation. And so he put the coffee stirrer in his mouth. This is how we practice that. And he plugged his nose so that he was just breathing through the coffee stirrer. And I was going to have him do that for however long until he started to feel some sensations. And maybe 5-10 seconds in, he quickly kind of whipped the straw out of his mouth and said oh my God, I can't do this. I have to get some water. And I said, okay, get some water, but please come back and let's talk about it. Let's talk about what just happened. So again, I'm calm. I'm not like, oh my God, I'm so sorry, this is terrible. I'm just like, okay, get some water in the waiting room, come back, have a seat. Let's talk about what just happened. And so he comes back and he said, oh my God, that's exactly what it's like. And it's so scary and even worse. And so essentially, and the reason I'm sharing this story with you is the therapeutic stance, right? My response to that is, wow, I said, I am sorry that you had such a strong reaction because maybe I didn't prepare you, enough for it. So I feel badly that that was terrifying for you. And at the same time, I feel like that's actually really helpful information. Like we just learned that, you know, we can do an exercise that really mimics what it feels like for you when you're feeling claustrophobic. And that made you feel so scared, showing me just how scary it is for you to have that sensation, you know, of a lack of air. We can totally capitalize on that in therapy, right? If you are willing to, I'm going to have you practice doing that exercise over and over and over again until you can lose your fear, right? Until you can realize that like there's nothing to be afraid of, that nothing catastrophic is going to happen, right? It was really scary for you, that was what happened, but nothing dangerous happened, right? And he was like, yeah, that's true. And so are you willing to do that again? And he's like, yeah, I'm willing to do it again. Like, so again, uncomfortable, but not dangerous. But again, my reaction to him was one of total calm and total confidence and kind of excitement. Like, this is huge, right? This is exactly, I'm so happy to know, like many patients do these exercises and feel somewhat bothered by it. You felt so bothered by it. This is the crux of the problem, right? This is the crux of your anxiety disorder, is that you get bothered by these sensations and then you avoid. Like, let's teach you to get used to the sensations and to not avoid. That's exactly what we want to do. And so he actually was willing to do the exercise a couple more times with me in session. And then after all of my sessions with all of my patients, I have them do a feedback form and basically rate their symptoms, but also give me feedback. What did you like the best about the session? And what did you like the least about the session? So this patient, what did you like the least about the session? Breathing through the coffee stir. What did you like the best about the session? Breathing through the coffee stir. And then he wrote, I kind of feel like I could have saved 30 years of therapy by just coming to you and practicing these exercises. Like, thank you. And this was a patient who was then super willing to do lots of exposure in session. And just to kind of tell you how, you know, we can then be creative is after we did the coffee stir for a while, you know, he was very sensitive to heat. So I had him come to session wearing lots of clothing and extra blankets, and we wrapped him up in blankets and had him get used to feeling hot. I put my space heater on my desk and I blasted him with heat with blankets on and a ski hat on. And again, that's exposure, but it's sort of the intersection between, you know, situational exposure and interoceptive exposure, because all of those exercises that we designed together, all of the exposure was meant to target sensations, right? All of them were meant to make him feel uncomfortable. And by the end, just be like a master of sitting with discomfort. And I saw him for maybe 6 to 8 sessions and he was good to go. So that's sort of, you know, my success story that I like to share. And there are lots more like that, but that one I thought was sort of a fun one because he went from feeling really freaked out to being, you know, really, really motivated and really appreciating just like the impact of interoceptive exposure. And so that also leads to this slide, which is that you can be really creative in your application of interoceptive exposure, as I was with him. So you can combine it with situational exposure. For example, a patient could hyperventilate in their car before going into a grocery store if they're anxious about going into a grocery store and having sensations. Let's say they do their grocery store exposure and then they realize they're not really afraid of it, but what they are afraid of is, what if I had a panic attack in a grocery store? Well, then you can try to sort of bring that on, evoke those sensations for them. If they're worried about having a racing heart while giving a speech, then in session, I'll have them do jumping jacks and then deliver their speech to me while standing with a racing heart, right? These are ways that we can combine interoceptive exposure with situational exposure. And also, as I said, I think of exposure as a therapeutic stance or a way of life for me, which means that whenever patients share with me, I kind of have these jokes with my patients, whenever you share with me anything that you're afraid of, you know I'm ultimately going to ask you to do that, right? To face that thing. So if you have a patient who has this fear of racing heart and they've given up coffee, it's not that I think coffee, I mean, I love coffee, but it's not that I think everybody must drink coffee. But if one used to love coffee and now they're avoiding it because they're afraid of a racing heart, well, I want to get them back to drinking coffee and enjoying it. So I'll have them practice, you know, drinking coffee, drinking extra coffee. If someone is afraid of stomach upset or stomach discomfort, we'll have them practice eating a couple of burritos, you know, again, uncomfortable, but not dangerous, right? I had a patient who one of his unique concerns was this tightness in his stomach. And so we kind of brainstormed and we came up with him doing a plank, which is an exercise where you kind of contract your abdominals. And we had him do long planks, which caused this like kind of stomach tension and tightness. So our joke was that we were helping him get a six-pack abs while also getting over his anxiety. But you can be really creative. And so I'm not going to ask you to share these with us today, but I want you guys to think that, you can be creative in your application of interoceptive exposure. So I'm just going to spend about 5 minutes now giving you a little bit of an overview of what are safety behaviors, because I think of interoceptive exposure, doing exposure and targeting or identifying safety behaviors as all being really important to getting over most anxiety disorders. And so a safety behavior is essentially a behavior that's performed by an anxious individual in an attempt to minimize or prevent a feared catastrophe. That's very jargony, but it's basically anything you do when you're anxious to try to make you less anxious in the moment is a safety behavior. Now, you all might be thinking, oh, I thought that was a coping strategy, right? Like I feel anxious, I try to make myself feel less anxious. Well, lots of your patients will come to therapy telling you that they have all of these great coping strategies, but you have to ask yourself, if it was a great coping strategy, then why would they be coming to see me? It might be helping them in the short term, but it is definitely not helping them in the long term. So these are examples of safety behaviors. They're things patients do in the moment when they feel anxious that help them feel less anxious. They're kind of control strategies, right? And all of these things are things that make them feel better in the short term, but that actually don't help them in the long term. And one of the things I have on here is using anti-anxiety medications. The short-acting ones are the ones I'm talking about, like benzodiazepines. These are safety behaviors. So verbal safety behaviors would be like saying, I have to repeat to myself, you're okay, you're okay, you're okay. Even a prayer, if it needs to be repeated, right? Now, I'm not against prayer. There are people who, are spiritual and use prayer, but when it has to be used repeatedly, when one is relying on it to feel calm in the moment, it is a safety behavior. Now, why is that a problem? So I'm going to talk to you about that on this slide. You're going like, oh, that seems helpful. Like, why is it a problem? The problem with relying on safety behaviors is that then when you are actually facing feared sensations, but you're doing it while like saying your mantra or drinking your water or taking your benzodiazepine or holding on for dear life, your fear doesn't actually decrease in the long run. You white knuckle it, you get through a situation, but you tell yourself, I got through it because I did A, B, C, and D, and I've got to do A, B, C, and D in order to get through it in the long run, right? So that's not a cure. Like I wouldn't be happy if my patient left therapy with all sorts of ways of getting through anxious situations. They're not cured, they're not over it, they're just white knuckling it, right? Because they believe the reason they survived is because they did these different things, which is magical thinking. We want our patients to realize that these situations are okay. They're not dangerous, that these sensations are okay, that they're not dangerous, not that they're okay because I did these different things to help me to be okay. Because the patient will ultimately conclude, if they're using safety behaviors, that it's the behavior rather than lack of danger that prevented this bad thing from happening, right? So they'll keep in their mind that the feeling, the thought that they need to control their anxiety. Patients will try to convince you that these are positive coping skills. You probably want to think that they're positive coping skills because it's easier, but they're not. And know that you have to ask your patient ask yourself, is the thing your patient is doing actually helping them in the long run? A brief example of this was that I actually do out of session exposure with my patients. Like I'll take them to the real world. And I had a patient who had panic disorder and he was quite afraid, as many patients with panic disorder are, of going to Costco when it's busy because it's big and busy, et cetera, et cetera. And so when we went there, and our intention was to have him, practice essentially walking around and tolerating his anxiety. And I won't go into great detail, but as soon as we got there, he said, oh, let me grab a cart. And I said, oh, but we're not shopping, right? Like we're going to be doing exposure together. You don't need a cart. We're not shopping today. And he was like, oh no, but I have to hold on to the cart because if I get anxious, I might pass out. And the cart, basically the cart will save me. So all of a sudden I go, oh, the cart is a safety behavior, right? He thinks he needs the cart so he doesn't pass out. But we all know that as much as our heart rate increases, we are not going to pass out, right? It's actually not possible to pass out when having, an elevated heart rate and basically anxiety and panic. And so I quickly said, oh, that's a safety behavior. We're actually not going to walk around using the cart today, right? I'm going to have you practice facing your fear. Now, that brings me to just my last few points on safety behaviors, which is you're wondering, what do we do about them, right? So the goal is to create a hierarchy with your patient of the different situations that they need to face using exposure, and to drop out their safety behaviors. So you can include safety behaviors on a hierarchy. I mean, I love to just give a rationale for getting rid of them altogether, but patients will sometimes want to hold on to safety behaviors, or you need to know then if we're going to include that in your hierarchy, it might be, for example, you can go to the grocery store pushing the cart as long as you're still feeling quite anxious, and so you're still exposing yourself. But the next time you practice, like when we try a little higher on the hierarchy, you're dropping out the safety behavior. So a lot of times I make a list of the safety behaviors and then make a list of the situations the patient's going to be facing. And if I can get my patient to drop out the safety behaviors altogether, great. But otherwise, we can include them on the hierarchy as long as the patient understands that they're going to need to let go of them as they progress, basically. So know that patients' anxiety will be highest when they're doing exposure without safety behaviors. You can also consider the costs and the benefits of using safety behaviors with your patient, right? The benefit is that in the short term, I might feel better and maybe be more willing to do some of these hard things. But in the long term, these safety behaviors are going to undermine the effectiveness of my treatment, and they're going to prevent me from getting over my anxiety. So at some point in treatment, you're definitely going to need to address and remove safety behaviors, and know that they will get in the way of new learning. And so it's always going to be in your patient's best interest to do exercises without safety behaviors. So these are sort of my final thoughts, and then I'm going to turn to your questions, which is our goal as therapists and patients is to lean into all sensations and not avoid them. I'd love you to start using interoceptive exposure to help your patients and yourself, if you need to, overcome a fear of physical sensations. That we're not going to be afraid to make our patients anxious. That is the whole point. We actually want to make our patients anxious and get really good at tolerating anxiety. And you want to help your patients to use exposure and interoceptive exposure to disprove their expectancies, right? To discover that the catastrophic belief is not actually true, and feel free to be creative in your application of interoceptive exposure. So I have 2 slides just to share with you. If people have listened to this and think, oh man, I want to try to refer my patients to you or your group, I'm just putting this slide up there, which is to say, you can always send patients to Feeling Good Institute. This is the main website, feelinggoodinstitute.com, and they can click on this big book a free consult yellow button and get connected with a therapist, and we'll always work hard to try to find them a good fit. And also, if you're interested in continuing to do any more training with us, we have free webinars on our website. We have on-demand courses. We actually have an exposure-focused consultation group if people are interested in learning more about this. If you're going, I want to do this, but I need a little more help, join our exposure-focused consultation group, learn how to do this with your patients. So you can learn all about our trainings and certification on the website as well. So now I'm going to turn to Mike and see, we have 8 minutes for final questions. And while I take some final questions, I'm putting this slide up in case anyone missed it, that there are requirements and you're going to need to make sure you fill out your CE survey at the end.
Awesome. Yeah, a ton of great questions. There's a couple that are asked numerous times. One is regarding telehealth and remote. What are ways that you kind of keep that in mind when you're doing interoceptive exposure?
Yeah, well, I do exactly the same stuff over telehealth as I do in person. So I do the same exercises, and with any kind of exposure that you're doing with a patient, you're setting it up for them ahead of time, telling them the rationale for it, letting them know what it might feel like, and asking if they're willing to do those exercises with you. But again, remember, these are not unsafe. So I don't really have, I've been doing this with my patients since, COVID began, and I started doing a lot more telehealth, and I don't really find that I'm making any different kinds of adjustments.
There's a lot of questions about nausea and how do you induce it and how do you work with that?
Yeah, well, that's a good question. Your patients might be your best teachers here because different things make different people nauseous. And so, if you have a patient who gets nauseous because of certain smells, then you could have them bring in things that smell. If your patient gets nauseous by certain images, you could watch videos online together. If they get nauseous when they get dizzy, you could do a spinning in a chair or a spinning exercise. Most people who are afraid of nausea are afraid of the discomfort itself. They haven't necessarily been so nauseous that they've thrown up. But some people are afraid of throwing up. And I will say I had one patient, I want to decatastrophize that. I'll share with you guys, I'm a pretty nauseous, car sick kind of person. I don't mean I'm a nauseous person, but I get motion sick really easily. That's the word. I've thrown up on planes. I've thrown up in cars. I don't stop traveling. I still do it all. My older son threw up on every single flight we ever took until he was 12 years old. We still traveled. So, throwing up is not intrinsically scary either. And so I would just encourage people, again, lean in, don't be afraid. It's okay to feel nauseous. It's even okay to throw up. I had one patient in my practice who actually did throw up in session doing exposure, and I just handed him the trash can. He threw up, he said, I think I'm gonna throw up. I gave him the trash can, he threw up, and then had some water, and then we continued our session because, again, that's not a catastrophe.
Another one that came up a number of times was if you have a client who's got a panic disorder, experiences fainting, her physician cleared her for interoceptive, but believes the fainting is due to hyperventilation. What are the suggestions when you work with somebody whose fear is fainting?
Yeah, so this is a great question. I'm glad you brought it up. Let me say one thing to be super clear, which is all of the fears and phobias and panic, other than what's called blood, injury, and injection phobias, lead to, so everything other than blood, injury, injection, lead to this kind of panic attack, racing heart, increase in adrenaline, sympathetic nervous system response, which everything I know and have read and have learned tells me you cannot pass out when your blood pressure increases, your heart rate increases, even if you're hyperventilating, that you're not actually going to pass out. The only exception to that are actually people who have fears of blood, injury, and injection. That phobia is actually quite different, and their blood pressure actually does drop, and those patients can pass out. And so I always want to, when I'm evaluating patients will always say, and I passed out, and then I say, oh, did you pass out, or were you afraid of passing out? And they're like, well, I felt lightheaded. Well, they didn't actually pass out, right? Passing out is blacking out, excuse me, and is dangerous, right? We don't want people to pass out. So what I would say is having a fear of passing out is totally different than having some history of passing out. And when I work with patients who have blood injury injection phobias, because there is a component, there's a portion of those patients who will pass out because their blood pressure actually drops, you just do a different kind of exercise with them. You do something that's called applied tension. You have them raise their blood pressure while doing exposure. That's a different category. So did I answer that question, or was there something else in there, Mike, that you think?
No, I think that addressed it pretty well. And I'm just looking at our time, Jill. There's so many great ones here, and so I'd love to do more, and feel badly that we can't get to all of them, but also want to honor people's time, and wondering if we should be wrapping up.
Sure. Yes, I was going to say I would take one more. So let me say before, I'll take one more question and see if I can speed answer it. Otherwise, I would say, there's lots of ways of connecting with us to do further training with us, consulting with us, that kind of thing. And if people really like this topic, I'm also happy to do more webinars on it in the future. If you're part of the team certification list, send an email and let us know that you want to see more webinars on these topics. And we'd be super happy to to do that as well. And just don't forget, my last announcements, don't forget to do the CE survey on the course page today if you're wanting CE credit. And then I'll take one more question. And then
Last quick one regarding kind of safety behaviors. Is it, if you're doing gradual exposure, is it okay to start off with someone with some safety behaviors and then gradually remove them?
Yeah, and I would say, again, it's like you're in your perfect world, your patient is not doing any safety behaviors. That's how they're going to get better faster, right? But if you're doing gradual exposure and you sort of have a hierarchy and your patient is not willing to do something really hard without their safety behavior, for example, a patient with a driving phobia who's like, I'm willing to do the driving, but I'd like my spouse to be in the car with me. I think that's an okay place to start, right? As long as they're still anxious, as long as they're still moderately anxious and you're actually having them face their fears, but know that ultimately they are going to need to do these exercises without safety behaviors to get where they need to go and to learn that there is actually nothing to fear. Okay, so we'll end there. Thank you, Mike, for your help today. And thanks everyone for your time and attention. And hope I get a chance to train with you guys some more one day. So thank you so much.